All right. Hey guys, how's it going?
Good, how are you?
Good. Okay, so today we're talking about the article on trigger point dry needling versus strain counter strain of the upper trap. So first off, let's just go around and talk about what we kind of liked about the article, just general feelings about it.
Um, well, like my first general feeling about it, so this is my third article reading on dry needling, and I've never done it. I've never seen it done. So it's definitely reading these have got me more interested in what that is. But article sake wise, I I thought it was a good article. Splitting it up into three groups. I think the sham group, I was a little, I guess, kind of lost on why they had them do like so much, or not so much, but they like actually actively pushed on it and stuff. Um, and then my concerns are, I guess, since we're all working on our methods right now. Um, but it's like, how do you? I think people's opinions on trigger points are like I mean, like all my athletes come in, they're like, oh, I have this like knot right here. And like, I'm like, is it causing any pain first off? And is it like, I mean, how do you measure how big it is? And I don't think they did a really like actual job. I mean, I know they said active trigger points, but I don't know, maybe I missed that if they like measured the size of it or the placement of that. And like, I think that could go into like how effective the treatment is too.
Yeah.
So I just
I
want to.
I definitely agree on that. Like, I think trigger points are kind of a subjective thing. So it's
Yeah.
really hard when you have a study that is looking at, let's see, they taught them, and they were actually physical therapy post-grad. They were in the post-grad program for physical therapy. So maybe they weren't students, and they were certified physical therapists. That was kind of unclear. But there were also 6 of them, which is kind of a lot of different people to be treating.
Yeah,
6 people, there could be a lot of variability.
Yeah.
yeah. Well, for me, this is actually the third time I've had to read this article because when I was an intern with USA Volleyball, they did dry needling a lot. And so they made us read a bunch of articles on it to try to like just teach us about it first. And so um,
Did you
I,
physically do dry needling?
I'm sorry.
Did you do dry needling when you were there?
We got to do it on ourselves. They didn't let us do it on the actual
Okay.
Olympiad. We were mostly just like observing and like doing laundry there, but that's fine. um, so that's the thing that popped up to me the first time I read it was that there was a bunch of different clinicians applying these interventions, and so the variability and the standardization of the application might have varied. Megan said as well. I'd be interested to see if the sham group, if they didn't palpate directly on the trigger point, but around the trigger point instead, because like as the article, like at the discussion, it talks about the gate control theory and how activating receptors over the trigger point could help alleviate the symptoms and increase the pain pressure threshold.
Yeah.
I'd be interested because they basically palpated on it and then did like circular motions or lateral movements over it. Yeah. So, I mean, I know that they didn't press to elicit pain, so they pressed until right before they elicited pain. That's still a sensory input.
Yeah,
those fibers.
Yeah, it seems like their sham group it should have been purely sham group. The person came and sat there, or whatever. So I thought that was really interesting. I don't think it's the greatest way to do this research or conduct that. But they definitely could have lowered the amount of clinicians, because I think dry needling is a little more objective, right? I don't know much about dry needling. Do you want to, Matt, you want to elaborate on kind of what it's doing?
Yeah, so I mean, there's a bunch of different reasonings behind using dry needling. For trigger points, usually they do it directly into the trigger point, and then like they said, they do an in and out technique, which is basically they stick the needle in and kind of go up and down a little bit, and then they pull it out, and then they do another needle, or not in the same exact application site, but around that.
Yeah.
As you do that, you'll actually get a twitch response, and so you continue to do that until that twitch response no longer is observable.
Sure.
And basically, by expanding the muscle fibers, like the needle goes in and expands the muscle fibers, it causes a stretch reflex, and so a relaxation almost.
Yeah.
So actually, we didn't really do that too much at USA Volleyball. We did more like dry needling for people that had like chronic rotator cuff issues, because it also causes a micro trauma and causes an inflammatory response.
Right.
Or blood to that area. So I didn't really see it too much with trigger points per se. But yeah, I mean, the way that they explained this, it seemed more objective and more systematic, that they were going right into the trigger point and that the protocol was the same for everybody.
Right.
Versus the strain counter strain. It kind of just, I mean, it's still like the methods that were still the same for everybody, but having different clinicians apply it, I think different pressures, ranges of motion and stuff could affect the results.
Yeah. Yeah. So I definitely think, you know, it would be okay to have multiple clinicians for the dry needling, because it is a little more objective. There are certain things to go through, but I think 6 was way too much for strain counter strain. Okay, so what did you guys think about the outcome measures and how they conducted that? What did you like? What did you not like? What did you, as a clinician reading this article, what would you have liked to see more of or changed?
So they used the Neck Disability Index, and I guess I've never really looked at the Neck Disability Index, and at first it threw me off because it was like, we use the Spanish version, and then I went back and read and understood that makes sense now. And then they used the Voss scale, which, I mean, I know that you can use that. It's just so, like, people's perception of their pain just varies like so much. Sorry.
That's okay.
And so I think that, like, I guess, I don't really love the Voss scale, but especially with, I don't know, trigger points, that pain, I think, varies so often. Like, if it's active for one day, it could not be active that next day, especially after treatment. So I don't know. I guess I don't really know much.
I think they did a good job of doing both clinician and patient rated outcomes, because they did the visual analog scale and the disability index, but then they also did pain with the pain pressure threshold and number to that. But something I would have liked to see is if they did some sort of range of motion measurements and see if patients that had a range of motion deficit in the C-spine because of a tight trap or a trigger point in the trap, that increased or decreased or remained the same or something like that. That's the only thing from a clinician standpoint that I would have liked to see.
Yeah.
I haven't had too much experience with like pain pressure threshold and actually measuring that, and so I had to go back and read a little bit on that and like what these numbers actually meant. But
yeah,
I mean,
I agree. I think pain pressure threshold, like, you don't really have one of those in your clinic, and so as a clinician, the outcome for me, it wasn't, you know, anything worth. It didn't really make sense, and it wasn't something that I would ever use in a clinic. I think it's good for this kind of research, but I think like adding that range of motion on top of it definitely would have made this a little more applicable, and just help you understand what you're changing. Sure, the physical touch pain was better, and as we get into the results, it got better, but I'm sure that range of motion probably didn't really increase with the sham group. And there might have been some differences between dry needling and actual strain counter strain treatment. So yeah, definitely agree on that. Okay, so results wise, what do you think it says about what we should be using? Obviously, we can't really use dry needling, at least from what I know.
California.
You can in California. In Arizona, when I was there the last 2 years, We actually had somebody sued for using needling, even though she was trained and her physician said she could. They threatened to take her license away and told her she couldn't do it anymore. So we can't really use dry needling, so that portion wasn't as wasn't as important as I was reading through on the methods. But with strain, counter strain, do you feel like the way they described it, you could recreate that?
I have I don't know. I don't know if you guys have read the other articles as well for this week, but they only did 90 seconds of strain counter strain.
Yeah.
Which that's one repetition of a strain counter strain. And usually when we're doing it in clinic, at least from when I use it, you find the most tender point and then you do it, but then you're also going to do it around that tender point as well. You're not going to do just one.
Right.
And so I felt that for their methods, if they did multiple bouts of strain counter strain, because if you look at the like the ART article this week, they did like 5 to 10 repetitions or something like that. So I'm interested to see if they did more repetitions than just one 90-second relaxation, if that would have affected anything. Because as a clinician, I don't know if you guys use strain counter strain. I do a lot because I only have my hands at Marshall. Mm-hmm. And I don't ever do just 90 seconds.
No. Yeah.
And they mentioned that in the discussion. They said, one of our limitations was that it was possible that the intervention wasn't applied. It was too short to achieve beneficial effects. But like that's what I was wondering during when I was reading it. I was like, I wonder how they came up with just doing a 90-second thing, because I always do it more than 90 seconds too, I guess.
I don't even think they cited a specific, reason why. Maybe I missed it.
I didn't see one either.
Yeah, they didn't cite like where they got this treatment from, and usually you kind of see that, especially if it's a specific, one specific.
They do.
Where was it?
Article
in the methods section, right after it says 90 seconds, it cites the article that they got that from. But that's only one set. Like that's just the recommended time for one set.
I see. Yeah.
So I'm just interested to see if they treated multiple tender points or trigger points, how that would have affected.
Yeah, absolutely.
And I'm just like a picture girl, so I mean I know what strain counter strain is, but I think just taking the time to even just show like a couple of pictures, it just makes your article like that much more beneficial.
Yeah, especially for people who have never used it. You're just learning about it. If you're just pulling up this article because you're interested in incorporating it. Yeah, for sure. Okay, so results. Let's synthesize those a little bit. So they found no significant difference between any of the treatments, right? All of the treatments decrease pain. And like even like we were talking about, even the sham with that light touch decreased pain and didn't see a huge significant difference, at least that they could report, between each. So what does this tell us about how we can use it in our clinical practice? Has this changed your mind? I don't know, does this encourage your amount of use of strain counter strain? Does it say, I don't really need to use it at all, I can just kind of rub on somebody? What do you guys think about that?
I think when I was first reading it, just like the overall discussion or the abstract when I was reading it, it was like no significant differences were found, or statistically significant differences were found. But when you read the results, it does say that the NDI was or significantly reduced in the strain counter strain group compared to the other ones.
Yeah.
Which we might have seen more if they would have done range of motion measures and see like that improvement. But once again, like you guys already know my opinions, I think trigger points are so on and off on some days. And so I think I always try to do something to help release that pressure. But yeah, I guess I'm not going to be dry needling soon.
Yeah, I'll agree with Megan. When I first read the abstract, I was like, there's no difference between a sham. Like, what the heck? And then so as I started reading the results section, and it even says like in the first paragraph, like there's no difference between anything. But then it goes on to explain that there was a significant decrease in the NDI for the strain counter strain group.
Mhm.
I think that from a clinician standpoint, actually having, like, I know the sham group still had the clinician's pressure and application on the patient, but actually moving them through the range of motion and kind of being more systematic about that. I don't know if that played into a role because the NDI is like the perceived disability for the patient. So I still think that it has its uses, especially for just reducing pain. Obviously, we see a reduction in pain for all of these. Like you said, we can't do dry needling. So if strain counter strain is going to be just as effective as dry needling, then I think I'm still going to use it. It's not like it's going to sway my position on using it for especially trigger points or tender points.
Yeah. Yeah, definitely. I agree. I mean, I think from what they described, I could maybe recreate it, but I would definitely do more in-depth a look into strain counter strain and different methods, because I don't feel like they described it well enough that I could really understand how to read it, right? For you guys, have you ever had like formal training on strain counter strain?
Just like a class,
Yeah.
like a class session, but no like formal, I guess.
Do you have any methods specifically that you guys use that you seem to be more productive? I know you use it a lot more, so.
Yeah. So I think like half of my football team last semester at one point had either hip flexor strains or hip flexor tightness, and so I used a lot of it with hip flexors and groins, and I don't know, I saw some pretty good results with it, just at least to decrease the amount of acute pain that they were in so that we could move on to some other exercises to help with whatever deficits, whether it was a weakness or a tightness issue.
Mm-hmm.
I had a manual therapy class in undergrad that we had a guest speaker come in and talk about it, but not anything more than, like Megan said, one class session, and then kind of just what I've picked up here and there. But I'm I guess I have had to grow in manual therapy in the past like 6 months because I don't have anything, and so I'm a firm believer in it now. So for, if anything else, just acute pain, like if it's not going to increase range of motion, if it's not going to help, the other articles talked about force production and rate of production. If it's not going to help with any of those, at least we know it's going to help with pain so that we can make them more comfortable so that they can go on to do more exercises.
Yeah. Agreed. What kind of treatments do you think you compare with this? That, they didn't do anything, but what kind of things could you complete the rehab after using strain counter strain? What kind of things do you use now, or do you think would be compatible?
So like after the treatment is applied, and then
Well, do you think, do you use it at the beginning? Do you use it at the end? We kind of talked about this, I think, a couple weeks ago with what was it? Some treatment. I mean, what do you think? Where and how would you place it in your practice?
Right now, I would probably place it with maybe doing some warm-up activity and then doing strengthening and range of motion and stretching afterwards, just to set the body and get it ready, and then strengthen what we just kind of fixed, I guess. But Matt might have a different opinion.
I mean, for me, it's variable. It's dependent upon each patient. So if I have somebody that has a weakness issue and they're not really having pain, maybe they had a strain, a week ago, and we're working on strength, and we start doing some exercises, and then they start tightening up and getting more pain, then towards the end of the treatment, I'll use this to kind of get them in a more comfortable, basically status before they leave for the day, so that when they come in the next day, they're not as sore, as much pain. In with a lot of pain, especially with like an acute injury, like especially acute muscle strain, just putting them in this relaxed position can help at least decrease the pain for the immediate acute effects. My office is usually like a circus during the day, so it's usually just dependent upon what each patient, their needs are and what I'm seeing with their rehab that day to determine when I'm going to use this.
Yeah. Yeah, definitely. Yeah, I think I like, I mean, both of you guys, it definitely varies. But I like warm up and then doing this, setting them kind of in a more relaxed position. Because if you're trying to do, especially upper trap, if you're trying to do some kind of strengthening and they've already got pain there, and then they're going to be doing the whole shrug thing on any kind of shoulder exercise. So definitely decreasing that pain. And then, putting them back. So back to a little bit of the methods, and maybe you guys can clarify this. So am I right that they came in for sessions within 3 weeks? What was it, 6?
Yeah.
6 sessions in 3 weeks, and then at the end of those all those sessions, they measured all of the outcome measures again, correct? So
yeah,
is that, yeah, that's right. So how do you think this might have changed if they would have then waited another couple weeks and measured again? Do you think this has like lasting effects, or especially like dry needling, or do you think the results would have changed?
I have no clue. I mean, no, I'm just I always like to see the long-term effects, but I guess I don't know how long-lasting these trigger points are, and hopefully by 6 treatments, they were reduced, but I don't know. I guess I would have liked to see if they like continue to have one, if the pain went away or not.
I think a lot of many articles talk about follow-up period, but I mean, even if we look at like just simple rehab exercises that we do with patients, we know that if they're not continuing them, that after some sort of washout period, those gains aren't going to be sustained. And so understand the reasoning for trying to do a follow-up and see which intervention may have had the longest lasting effects. In clinical practice, we're going to be seeing them pretty consistently usually. And so if it would change anything if a follow-up period was measured and there was a difference, because I think 2 weeks, 3 weeks doesn't really matter. We're still going to be seeing them in that time period, typically.
Yeah. There's always that athlete that they're like, oh, I'm fixed, I feel great, and you don't see them for a couple weeks because they're like, nothing's going on, and then they come back in a month because it's all returned. So yeah, I definitely think it's a treatment that is easy enough to do and easy enough to work into your everyday treatments, that it's not a hassle to see somebody once or twice a week, to just continue working on those things and then send them home with the home exercise program, right? I think that's what I took most out of this article and this method, is that, and a lot of these manual therapies, is that they're easy enough, they don't take long amounts of time, that you can apply them, teach them correct movement, send them on their way, and see them again in a week. And hopefully that sustains them for however long, and eventually it goes away. But awesome.
Yeah, I think one of the first readings that we had this semester drove home the point of manual therapy and saying that it's not going to be your end all be all. Mm-hmm. It's just a tool to help you achieve, like you said, better movement patterns and better corrective exercises for the patients to improve their status, rather than just getting this manual therapy and they're going to be fixed.
Right. Definitely. And I think this is a good class to pair after what we did last semester, with kind of eval and then like treatment algorithm, all that stuff, because I think it's we can kind of, as we learn these different techniques, plug these into those treatment algorithms. Like, okay, here, oh, this is a good place for this, and this is a good place for this. And it kind of gives us more tools in our toolbox if you haven't been using this yet. That's where I'm kind of, you get into a pattern of using the same general things, and this is a nice refresher just to, because none of them are too cumbersome. It's not like it's taking you a long time, so you can simply work it into a treatment, you know.
I agree with
I
you.
have a question for you.
Yeah.
Just a comment. I think it was kind of interesting how none of the patients that were receiving dry needling dropped out, but 2 patients that were doing the strain counter strain because of discomfort. Do you guys find that interesting? Do you guys have any comments on that? I just thought that was pretty funny because I'm terrified of needles personally. And so doing on myself, I was like, this sucks, this sucks, this sucks. But strain counter strain is very passive manual therapy. And so I didn't really comprehend why the subjects dropped.
Are you looking at the first paragraph of the results?
Yeah, and the results were, or the sham treatment. Sorry, they got the sham.
Oh, I was gonna say, because in this first paragraph it says the total number was 34, and then despite having aversion to needles as an exclusion criteria, 2 participants randomized to the dry needling group withdrew from the study because they did not want to be dry needled. You see that?
Right, but then on page 176.
Yeah. Oh,
so at the start of 174. It's talking about how dry needling is safe, and
oh yeah,
none of the subjects were dropped because of after receiving the dry needling group. But then it says 2 patients allocated to the sham and then 1 to the strain counter strain discontinued because they basically did not like the treatment.
That's interesting, right?
I wonder if it was just, I mean, they say,
yeah, I just found that.
Didn't want to come in 6 times.
Yeah, like non-compliance maybe. They just decided it was going to be too much and they didn't want it. Or they didn't see its benefits. Maybe they weren't seeing benefits and they were like, yeah, I'm good.
Yeah.
That was really interesting. Yeah, I wonder, have you guys, I mean, what is your patient feedback when it comes to strain counter strain? Do people usually like it? Do they feel discomfort, but they push through it? What do you guys think?
It is such a passive thing. My students love it because they're like, I don't have to do anything for this. I've never had anyone where they're like, oh no, quit, it's too much pain. So, because you kind of go on if they're having, like, what their pain level is too, on how far you're pushing.
That's true.
I will agree. I've had some pretty positive feedback from patients just because it's a very passive movement, but I have had one patient who had a hip flexor strain kind of linger for a while. And we tried to do this, and no matter what position I put him in, he was just in pain and we could not alleviate his symptoms. And I think he also began to grow frustrated because we had done this before and he had positive results. And so the couple times that we did it and he did not, I could see the frustration growing on his face. And so I think that caused him to tense up more and to not buy into it as well and not be as relaxed as he should have been. So that's pretty much the only time I've had a negative result with it, or not, I guess not a negative result, but not seeing the outcome that we were looking for.
Yeah, absolutely. Yeah, I think some of those more tender patients, it doesn't happen a lot, but if they actually have something going on, this can be counterproductive almost. All right. Any other thoughts about the articles or the article, questions, topics you guys want to bring up?
I think we covered it, like all of it or quite a bit of it. I just want to know, like, when I'm going to be able to do dry needling. You guys can't give me that answers.
Yeah, we keep reading all these articles about dry needling, and maybe Dr. Powden will see this and tell us something different, but I'm pretty sure we can't. And even if we got trained, I'm not sure we're allowed, but because PT sometimes gets a little territorial and they make these laws that we can't do certain things because of that, or they try and pass laws. I know they did in Arizona when I was there. They tried to pass a law that we couldn't treat anything except for emergency care. We couldn't do any rehab. And that was really, really crazy. But thankfully, it didn't pass, but they tried
One of the major groups fighting against athletic trainers getting licensure in California is the California PT Association, because they feel like the athletic trainers will start stealing their patients, because right now, not a lot of high schools in California have athletic trainers. So when athletes get hurt, they get referred to physical therapists. So if athletic training becomes a regulated practice, more high schools will hire athletic trainers and in-house rehab, basically. So.
And your governor.
Yeah.
Yeah, he's not for it, huh?
I learned that from Terry Lynn last week, so that's the only reason I know that. But.
Yeah.
Yeah.
Super crazy. Okay, yeah, let's hope that we can get some clarification on dry needling, and hey, maybe we'll get to use it soon. Yeah. I think it would be really cool. I think it's right along what we do anyways. Especially with the changes in the profession, I think dry needling isn't that far away.
Yeah. And I mean, the gauges on these needles are so small that it doesn't even cause, like, it's not like when you pull the needle out, like when you get a shot and you pull the needle out and they have to put a Band-Aid on it. There's not even a Band-Aid required. Like, the gauges are tiny. It's basically just to get a little stretch in the sarcomere.
Yeah. Unfortunately, I think I definitely think it needs to be something that is like very well trained, and you need to have good athletic trainers doing it. And what ruins it is some people just start sticking needles, and it becomes an issue. But let's hope as we progress as a profession, this becomes something we can do, because I think it would be really beneficial.
I think so too.
All right. Cool, guys.
Well, nice conversation.
Yeah, it was great. And we'll talk to you again soon.
Okay.
Okay. See ya.